welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Third and final presenter is going to be Magda Jasinska, PGY2 critical care resident from UNC Health Rex, who will be presenting on the efficacy and safety of ketamine or Ketorolac compared to opioids in painful vaso-occlusive crisis.
I've included the notable abbreviations that I'll be using in my slides here for your reference. And today we'll discuss the prevalence of sickle cell disease and vaso-occlusive crisis in the United States. We'll compare treatment options for vaso-occlusive crisis in both pediatric and adult populations. We'll identify guideline recommendations for the treatment of vaso-occlusive crisis and analyze evidence regarding the place and therapy of both ketamine or Ketorolac in vaso-occlusive crisis. And lastly, we'll identify patients that would benefit from ketamine or Ketorolac for vaso-occlusive crisis. So for a little bit of background, sickle cell disease is an autosomal recessive genetic disorder that affects patients primarily of African, Middle Eastern, Mediterranean, Central and South American, and South Asian descent. It causes a mutation in our beta globin gene that causes hemoglobin to polymerize and sickling of red blood cells, which eventually block blood flow. And this blockage of blood flow is referred to as vaso-occlusion. Vaso-occlusive crisis can be triggered by a variety of factors, most commonly by dehydration, inflammation, or extreme temperature changes, and it presents with severe pain. In the United States, we have about 100,000 patients with sickle cell disease, and over 50% of these patients, both adult and children, have at least one opioid prescription with a mean day supply of 4.3 days. A single vaso-occlusive crisis episode can last about 7 days, and it's the most common cause of hospitalization in sickle cell disease, and it may occur anywhere from 3 to 10 times per year per patient. These patients require a lot of opioids for their pain management. The daily morphine milligram equivalent dose during an admission for vaso-occlusive crisis pain can range anywhere from 10 to over 250 milligrams per day. And this is all to show that both chronically and during a vaso-occlusive crisis, these patients are in severe pain and rely on heavy doses of opioids to help manage that pain. So we are looking at alternative agents in order to help mitigate some of the side effects that come with opioids. Additionally, the American Society of Hematology does have recommendations for pain management in acute pain crisis and sickle cell disease. Those recommendations are very general, applying both to adults and children, and they recommend a tailored opioid dosing strategy. They do not make any recommendations for basal versus bolus opioid dosing. They recommend a short course from 5 to 7 days of NSAIDs in addition to opioids. And they also recommend sub-anesthetic ketamine infusions for refractory pain. And lastly, they recommend regional anesthesia for refractory pain. So all of these are very general and do not provide a lot of guidance for which agent should be used after opioids are not tolerated or not sufficient. In general, for vaso-occlusive crisis, we have 3 main types of medications that patients rely on. So opioids, such as fentanyl, hydrocodone, morphine, and oxycodone, to name a few, target our mu opioid receptors to provide pain relief. These are quick onset pain relievers. However, they do have the risk of physical dependence, CNS or respiratory depression, or hyperalgesia with chronic use. NSAIDs, such as Ketorolac or ibuprofen, target COX enzymes, and they may be opioid sparing and highly accessible, so just over-the-counter ibuprofen. However, they do carry the risk of GI ulceration, adverse cardiovascular events, acute kidney injury, or bleeding. Additionally, NSAIDs are typically contraindicated in pregnancy, and Ketorolac does carry the black box warning to avoid its use in pediatric patients. Lastly, we also have ketamine, which is an NMDA receptor antagonist that is also theorized to improve opioid activity at the mu opioid receptor. It can be beneficial in a multimodal pain regimen. However, it does also carry the risk of emergence reactions, specifically in adult patients, or hypertension. So the article that I'll be discussing more today is called The Efficacy and Safety of Ketamine or Ketorolac Compared to Opioids in Painful Vaso-Occlusive Crisis, Systematic Review and Meta-Analysis. The authors looked at Embase, Medline, and the Cochrane Register to find their studies. They searched terms such as ketamine, ketorolac, randomized controlled trial, and variations of sickle cell disease and vaso-occlusive crisis. They included patients that were included in randomized controlled trials or any studies that looked at the efficacy and safety of ketamine or ketorolac compared to opioids in patients diagnosed with acute painful vaso-occlusive crisis. They excluded any studies that were non-randomized controlled, any studies that used ketamine or ketorolac for non-vaso-occlusive pain, or any studies that used ketamine or ketorolac as part of an adjunctive multimodal analgesia regimen outside of opioids. Ultimately, the authors screened 62 records and were able to include 8 of those in their final analysis. Data collection was completed by the independent review of 2 authors. Their efficacy endpoints were pain reduction on pain scales and a reduction in opioid requirements, which they reported in morphine milligram equivalents. They also recorded safety endpoint of incidence of adverse effects. They did a quality assessment of each of the studies, looking at the risk of bias and heterogeneity of the studies. They also ran a meta-analysis that looked at the standard mean difference of meaningful pain reduction with ketorolac, the mean difference of meaningful pain reduction with ketamine, and the reduction in opioid requirements. And the authors concluded that a p-value of less than 0.05 would be considered statistically significant in their analysis. So this is an example of the pain scales that are often used in practice and that were used in these studies. These scales show progressively uncomfortable facial expressions that help patients, specifically pediatric patients, rate their pain. 3 scales were used in the studies included in this article, and those are the visual analog scale, the numerical pain rating score, and the facial pain score. The authors determined that a reduction of 3 or more on a 10-point scale would be clinically meaningful, or a reduction of 13 or more on a 100-point scale would be clinically meaningful. So the ketamine studies, there were 2 studies that were included in the final analysis. This included 278 children and 240 adults. Both of these studies were assessed to have a low risk of bias by the authors. The dosing strategies on the right show that the IV ketamine dose of 0.3 milligrams per kilogram as a one-time dose was compared to IV morphine, 0.1 milligrams per kilogram as a one-time dose. And this was the dosing strategy used in adult patients. And the second dosing strategy, IV ketamine of 1 milligram per kilogram compared to IV morphine, 0.1 milligram per kilogram, was the dosing strategy used in the pediatric study. Overall, the 2 studies found that ketamine did not have a statistically significant pain reduction compared to opioids in pediatric or adult patients. However, ketamine did have a statistically significantly higher incidence of adverse effects. So this was both overall adverse effects, GI adverse effects, and specifically nausea, vomiting. Additionally, the authors found a statistically significantly higher incidence of CNS depression with ketamine compared to opioids. And this is not surprising looking at specifically the pediatric dosing of ketamine, which is similar to that of what we would use for procedural sedation in the ED for pediatric patients. So we anticipate that would cause a lot of CNS depression. And for the Ketorolac analysis, this included 6 studies. This was a combined population of 251 patients, both adults and children. The authors were not able to include a specific number of adults versus children, so this is just the combined number. 4 of these studies were considered to have some concern for risk of bias. 1 study had a low risk of bias, and 1 study had a high risk of bias. The dosing strategies on the right show that there was a very wide variety of both route, frequency, and dose of ketorolac that was used, anywhere from IV to IM dosing, a single flat dose, or continuous infusion, or weight-based dosing. All of those were used with or without additional opioids, and all of these were compared to an opioid dose. For the Ketorolac studies, the authors found that there was a statistically significant pain reduction with Ketorolac compared to opioids. They also found a statistically significant reduction in adverse effects with Ketorolac compared to opioids. And this was seen in the overall adverse effects group, in the GI and specifically nausea and vomiting adverse effects, and CNS depression. There was no difference between Ketorolac and opioids in terms of dyspepsia incidence. And the overall efficacy outcome that the authors looked at was overall opioid reduction. So in terms of MME, the authors found a statistically significant reduction in MMEs used by these patients when ketamine or ketorolac was added to their regimen. Overall, this study had multiple strengths, including the fact that they assessed both efficacy and safety of these alternative agents when compared to opioids alone. They also included a significant pediatric population, and we know that vaso-occlusive crisis can occur in both pediatric and adult populations, so this improves our generalizability of the results to practice. They also assessed the safety of a current off-label practice, which is using ketorolac in pediatric populations, and were able to determine that this was safe in those populations. However, they did only include 2 studies that assessed ketamine, and only one of the studies included in the overall opioid reduction subgroup included ketamine use. So this may show that our overall pain reduction outcome may be driven by the ketorolac studies. Also, they did not include any information about history of GI bleeding, psychiatric conditions, or other risk factors that may predispose patients to certain adverse effects from these agents. The authors concluded that both ketamine and ketorolac are effective as opioid-sparing options for vaso-occlusive crisis, with an average of 3.23 MME reduction. Ketamine achieves similar analgesic effects to opioids, but the side effect profile may limit its place in therapy. Ketorolac was superior to opioids for pain reduction and also had a significant decrease in side effects. And despite the black box warning, ketorolac was successfully used in pediatric patients for vaso-occlusive crisis pain. Additionally, opioids are no longer considered the mainstay of vaso-occlusive pain management, since we do know that there are alternative agents that do not carry the same risks as opioids that are equally as effective or more effective. And lastly, specific patient risk factors need to be considered when choosing adjunct agents for pain management. So overall, when we're applying the results of these studies in our practice, we need to consider patient-specific risk factors and their preferences when discussing the side effect profiles of different agents. We know that ketamine is an effective adjunct agent to reduce opioid exposure and improves pain scores similar to opioids. Ketorolac has been used in pediatric populations and may be an option for refractory pain, but we need more studies to evaluate adverse effect incidence based on patient risk factors. So moving forward, I encourage you to consider how you use ketorolac and ketamine in vaso-occlusive crisis at your institution, and what future directions for vaso-occlusive management you would like to see to guide practice. So overall, we discussed that vaso-occlusive crisis and pain management take a significant toll on both patients and health systems. Our current treatment with opioids is effective, but does expose patients to certain risks that can be mitigated when we add additional adjunct agents. And lastly, ketamine and ketorolac have been successfully used to decrease opioid exposure in both adult and pediatric populations. So thank you for your attention today, and thank you to my mentors, Erilyn, Akil, and Patrick, for their help in making these slides. I'll take any questions that you have now.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest. It should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.